This lecture describes the background, rationale and development of a multimodal monitoring or 3M strategy to improve outcome in high-risk surgical patients. My name is David Green. I'm an honorary consultant anaesthetist and senior lecturer at King's Health Partners and King's College Hospital based in London in the UK, and this lecture was given to a hemodynamic meeting held in Karlovac in Croatia in November 2017. The aims and objectives of this lecture. I first of all want to highlight the problem of managing the increasing number and poor outcome of elective and urgent high-risk surgical patients, and this especially applies to the elderly and is really the rationale why we need a new strategy, as we'll see. It's becoming increasingly important not only to maintain mean systemic blood pressure, mean arterial pressure, but at the same time also cardiac output and oxygen delivery. But at the same time, we mustn't be achieving this with excessive amounts of fluid and sodium and unnecessary inotropes. So we have a dilemma, the requirement to maintain mean arterial pressure and cardiac output, but at the same time avoiding circulatory overload and unnecessary inotropes. I believe that current hemodynamic management strategies, and there are many, using flow monitoring, are based on misunderstandings of circulatory physiology and have not brought and will not bring, sadly, the hoped for benefits. I believe that using an intraoperative 3M strategy enables us to maintain mean arterial pressure, oxygen delivery and tissue oxygenation, and this translates into better management and improved outcomes for our high-risk elderly elective surgical patients. Where have we gone wrong in our strategy after the introduction of flow monitoring? Well, I believe we're using either the wrong monitors or the wrong combination of monitors. When we have a monitor at our disposal, we often use the wrong intervention strategy and therefore don't get the best out of the monitor. And in addition, in some cases we're looking at the wrong patient groups. Patients who may not perhaps benefit by sophisticated monitoring, perhaps using less than ideal strategies, and thus we're not seeing an improvement in outcome, leading people to despair and say, well, new monitors don't help us. But a lot of people, a lot of anaesthetists especially, do not admit there is a problem. Aren't we getting it all right already? Professor Tom Healy, who was not only professor in Manchester but also editor for a number of years at our European Journal of Anaesthesiology, made this statement: anaesthesia is a disease that's being cured. In other words, as we'll see, mortality under the care of the anaesthetist is very low, and thus what more could we do to improve the circumstances? This, of course, has the effect of certainly not encouraging investment in anaesthesia research. So the premise often is, well, look, anaesthesia is completely safe, isn't it? But when we look at the overall surgical outcome of our patients, we know that that is certainly not true. Now, this state of UK anaesthesia, which was a snapshot of anaesthetic and NHS activity in 2013 as part of our Royal College National Audit Project on awareness, accidental awareness under general anaesthesia, by looking at their local representatives in every hospital and finding out about mortality, found that mortality was indeed very low, 1 in 2,000 during surgery, but this was under the care of the anaesthetist. That means very few people died on the operating table or as the patient was taken into the recovery area or the intensive care. Didn't say anything about later outcome. But we know from several studies, the recent ISOS study, 1 in 200 die in hospital, and looking perhaps nearer to home, the figure of 1 in 25 in hospital mortality in the USOS study suggests that the actual overall mortality may be very low under the care of the anaesthetist, but it certainly isn't so in the whole surgical course. There may be anything up to an 80-fold difference. To give them credit, this group of workers said these differences highlight the potential impact or advances in perioperative care might give us to improve outcome on overall mortality rates. And notice they said 3 groups were involved: anaesthetists, surgeons, and I've underlined surgeons because they've made a lot of progress, and intensivists. And we've tended to rely on intensivists basically to try and, save the situation. I believe if you have to go to an intensivist, it's a bit too late. So how do we close the gap between 1 in 2,000 getting the patient off the table and as much as 1 in 80 or even higher in overall hospital mortality? Well, I want to start off by making a statement on intraoperative monitoring. There have been no major advances, really, in routine intraoperative monitoring from around 1984, when the pulse oximeter was then freely available. We had end-tidal carbon dioxide in a system which could be used routinely during anaesthesia in the mid to late 70s, and we also had anaesthetic agent monitoring. We had to move forward a full 27 years. That is easily the career of a consultant anaesthetist in the United Kingdom before we had further advice, basically. And I just want to show this picture of our monitoring setup in 1989. This is KCH Theatres, Theatre 3. It looks a bit cluttered possibly, but on that setup 28 years ago we have all the monitoring that most people would use routinely today. And it's interesting that the Harvard standards of monitoring, introduced in 1986, which are always said to have made a radical difference to improve outcome under the care of the anaesthetist, did not include end-tidal carbon dioxide or pulse oximetry. And indeed, if we move forward, for example, to 2016, this is a classic anaesthetic setup these days, classic anaesthetic machine. However, it contains no different monitoring to what we saw in 1989. In other words, there's been no difference or advances in anaesthetic monitoring. In 2011, flow and then depth of anaesthesia in 2012 monitoring was advocated. These are 2 of the components of multimodal monitoring, incidentally, by our National Institute for Health and Care Excellence for higher risk patients, especially the elderly. But this advice has been essentially ignored in most circumstances. And the problem, and this is why many people have ignored these advances, is that recent key trials suggest that neither complications nor mortality are reduced by the addition of hemodynamic monitoring on its own. And interestingly, when we look at it on its own, no studies have additionally used depth of anaesthesia or tissue oxygen monitoring alongside flow monitoring. So people have looked just simply at the introduction of flow monitoring. 30-day, as I say, and in-hospital mortality remains stubbornly high at around 4 to 5% in high-risk elderly patients. I believe we urgently need to revisit circulatory physiology under anaesthesia to explain this dilemma and where I think we are going wrong. So when we look at the problems of high-risk surgery in the UK and elsewhere, what we found from the NAP5 study I just mentioned, with the 3 million operations, that 1 million, 1/3 of those operations, were on patients over 65, and yet they only constitute about 1/6 of the population. So they're already 2 times as many operations as you would expect from their numbers. In some studies in the United States, it's even worse. They may undergo surgery 4 times more often than the young. So there's a tremendous burden on the anaesthetic and surgical services. And when you combine that with high risk and limited cardiorespiratory and cognitive reserve, you will obviously see that there is problems in dealing with these patients. And when we look at depth of anaesthesia monitoring, for example, we find there's a very narrow gap between giving these patients the right amount of anaesthetic versus too little or too much. And this was recognised by our National Institute of Health and Care Excellence in 2012. Now, a large prospective study carried out in Australia specifically at patients over 70, the vast majority were elective, found that 5% of these patients died within 30 days of surgery. Remember the 4% figure from USOS? That was in mainly lowish risk patients. This was in high risk patients, but we're talking about 1 in 20 now were dying in the first 30 days after surgery. And some studies, interestingly, have shown that if you just survive 30 days may not mean that you go on to survive long term after that. So this is just looking at the first 30 days. Now this group in Australia said strategies are needed to reduce complications and mortality in older surgical patients. Now that's clear. If 1 in 20 of your patients are dying in 30 days, strategies are certainly needed. You can't ignore statistics like that. The problem is this group didn't come up with any strategy. I believe strategies and protocols need monitors, 3M, to guide our management, not recipe books. For monitors to improve outcome, we need suitable and physiologically based protocols which it's possible to adhere to. It's no point in having an impossibly difficult protocol to adhere to, so it's got to be able to be adhered to, and then you've got to see that in your results, patients in that intervention group, that strategy was adhered to. So there are two components to that, the right strategy and it being adhered to. But the bottom line, in all our elderly, frail patients, and indeed in all our surgical patients, we need to individualize patient care, and we need to accept fundamentally as anaesthetists, deficiencies in intraoperative management are deleterious for long-term patient outcomes. So just because you get your patient off the table or into the post-anaesthesia care unit or the high dependence unit does not necessarily mean that you haven't started a process during surgery which eventually leads to poor outcome of the patient. So two questions arise from these statistics. Number one, what's accounting for such a high mortality? These are patients, mainly elective patients. Why do we get such high mortality? And secondly, very importantly, obviously, can we intervene to reduce the risk of mortality? I think we get some clues, but I think the major one has come from this sort of study, which is the association of post-operative high sensitivity troponin levels, that's HSTNT, with myocardial injury and 30-day mortality among patients undergoing non-cardiac surgery. And in this lecture I'm going to concentrate on non-cardiac surgery, incidentally. This is a prospective study of 22,000 patients, interestingly. Among the nearly 4,000 patients, 18% of this population with myocardial injury, MINS, 93% did not experience an ischemic symptom. So if you say to me, my patients don't get any myocardial injury after non-cardiac surgery, unless you measure HSTNT, then you're going to miss 93% of these patients. Is HSTNT, on the other hand, an important predictor of poor outcome? Yes, it is. High HSTNT was directly associated with 30-day mortality, with or without ischemic symptoms. So on its own, it can predict poor outcome. The higher the level, the higher the risk of mortality after surgery. This, I think, provides irrefutable evidence that we should be measuring HSTNT routinely in high-risk patients group, including preoperatively, incidentally. And this point was made by Professor Dan Sessler from the Cleveland Clinic last year in the ASA meeting in his Severinghouse lecture, which was published earlier this year in anesthesiology, and he repeated that statement this year in Boston. Now, we've had equivalent to HSTNT available in Europe and the United Kingdom for longer than they have in the United States. So in a subset of the optimized trial, which is, we'll mention that, which is the largest prospective study of outcome using a goal-directed intervention study, they looked at cardiac biomarkers. Now, interestingly, what they were trying to prove was that their intervention in the optimized study of fluids and inotropes such as dopexamine did not increase the risk of myocardial injury. Not it produced a massive reduction, but that it did not increase. Well, they did show that, but when you look at the degree of myocardial injury, I think it's quite an astonishing statistic. You can see at the 24-hour time point 30% in both groups, and at 72 hours 40% had above the upper reference limit, showing they were having myocardial injury. and this was reflected in the mortality, as we'll see later. But don't forget, this was not a particularly high-risk patient group, not by some other study standards. 65% of patients in the intervention group were ASA2 or less, and yet they had a vast degree of myocardial injury. So the question then is, well, if we say myocardial injury is one of the main factors, which I believe it is, there are others of course, but I think it's one of the major factors, why is it that 40% of patients at 3 days show evidence of myocardial injury after major surgery? Well, I think we need to look very closely at blood pressure, and this is being done in many trials. This is just one of them, but one of the better ones by Terry Monk, looking at hypotension and this associated with mortality. She looked at a large group of patients in the VA system in the States, looking at 30-day mortality, and they had an automated hemodynamic database, so they were able to look at time-based thresholds of hypotension. They chose relatively low pressures, systolic 70, mean of 50, and mean of 50, 55 is often seen to be the threshold where you start getting problems, and 30 millimeters for diastolic, respectively, for just more than 5 minutes. In other words, between the measurement of one blood pressure and another, often using a cuff system, for more than 5 minutes, led to a threefold increase in 30-day mortality. So we can't afford to be complacent about blood pressure measurement, and perhaps, as we'll see later, we should measure blood pressure much more frequently on a routine basis. So it's crucial then we know not only what's happening to mean arterial pressure on a regular basis, but also how is cardiac output affected during induction and maintenance, because we need to make appropriate interventions to try and maintain pressure, and we at the same time need to make sure that we're not affecting other things like cardiac output and oxygen delivery. Now the LiDCO Rapid, in my opinion, is the best monitor for monitoring blood pressure and then cardiac output and stroke volume intraoperatively using a radial artery line. There are many other types of systems using femoral artery, etc., but intraoperatively. Now we started using LiDCO technology back in 2006, that's nearly 12 years ago now in fact, and in 2008 we started using the LiDCO Rapid, and if you look at the data there, you can see highlighted its elderly, high risk, long duration procedures, and we'll see the rationale for looking at long procedures in a moment. What we found interesting enough, because we put in the arterial line pre-induction and got the first measures of stroke volume, nominal stroke volume in some cases, and cardiac output from pre-induction. And what we did was we corrected all the starting cardiac outputs to 10 litres, and we indicate on this slide where propofol was given, the anaesthetic. And then we followed cardiac output over the next 30 minutes or so. And what we found was a dramatic fall in cardiac output over induction using BIS-targeted anaesthesia. So this was using very careful anaesthesia. There was a fall of about, somewhere in the region of about 40% in cardiac output. We later on corrected that, but we'll see that was what was going on. Now I give great thanks to Mert Kamenik and Merla Petron in Maribor, because they looked at a controlled study, a randomized controlled study, blinded study, looking at precisely this fact, but comparing propofol and etomidate. So they started induction at this point here, as you can see, and they followed etomidate and propofol, and then other anesthetics obviously over the first 10 to 15 minutes or so. What they found, not surprisingly, was the 30% drop in mean arterial pressure, which everybody notices. But like our work, they also discovered that there was a concomitant drop in cardiac index, and in fact the drop in mean arterial pressure was driven almost entirely by the fall in cardiac output in both groups. So the fall in pressure is driven by a fall in cardiac output over induction. That, I believe, is the major cause of this fall in mean arterial pressure. And the question is why? Why do we get a fall in cardiac output? Because we can't afford to drop cardiac output by that degree for too long a period, as we'll see. Well, we have to go back to the history books, basically. We have to go back to 1961 to get a clue as to what was going on. And this is a paper by Professor Sharpie Schaefer in the BMJ, published in December 1961, and he was studying venous tone. Venous tone. He was interested in that because ganglion blocking drugs had very recently been introduced as the first drug treatment of hypertension. We're so used now to using ACE inhibitors and beta blockers and alpha blockers and so on. Go back 50 to 60 years and we find that in fact the only drugs available until late 60s, early 70s were ganglion blocking drugs, and they had profound effects on blood pressure. He found that the changes could occur very rapidly, and he made this very profound statement, I think, which is very relevant today. It is clear that the usual clinical practice of following such cases, which was hypotension with ganglion blocking drugs, but we could equally say hypotension over induction, by the measurement of arterial pressure by the antiquated cuff method, can be of limited value. In other words, it wasn't quick enough. And as we've just seen, the same applies to induction and maintenance of anaesthesia, doesn't it? He also found, most interestingly, that when you started becoming anemic, for example renal failure patients, or you were in heart failure, venous tone was greatly increased. So it would appear that the elderly and high risk patients have the highest venous tone, so they're probably at the greatest risk, the greatest danger if you have a venodilation. He also went on to say, and I think this is perhaps the most interesting outcome of the study, it appears that the veins and not the arteries are the major factor in causing hypotension. In other words, we always think of the arteries dilating, dropping the blood pressure, but it's not, it's the veins. Is this same true with anaesthetic drugs? Well, I just really want to quote one paper here by Goodchild and Soraya from Leeds on the cardiovascular effects of propofol in the anaesthetized dog. This was published in 1989. And what they found was, not surprisingly, anaesthesia with propofol is accompanied by decreased mean arterial pressure. And of course it's quite dramatic. But it was also accompanied by a fall in cardiac output. There was no change in systemic vascular resistance, which might be attributable to arteriolar dilation. They found it was due to an increase in venous capacitance. So the decreased cardiac output, they found, was secondary to venodilation and then reduction in preload. Venous tone is very important. The tension of the venous system is what's the driving pressure that's pushing blood back into the right heart and round the circulation again. If you take off that tension, then although the venous compartment remains the same, the driving pressure drops, and so does the stroke volume. They found that the cardiac output and mean arterial pressure in this study are preserved as long as preload is maintained by maintaining CVP. So as they gave the propofol, the CVP dropped. If they kept the dogs topped up with fluid, they could maintain cardiac output and mean arterial pressure. When you think about it, in clinical practice, should we be doing, or are we doing the same thing? Are we actually giving fluids just to maintain venous capacitance? Well, in fact, if we go back to 1961, we can see where the great shift in practice took place in fluid management during anaesthesia as a result of this paper published by Shires, Williams and Browns from Parkland Hospital in Dallas, where they described the acute change in extracellular fluids associated with major surgical procedures using a triple dilution technique. They found this loss of functional extracellular fluid. In other words, you still have extracellular fluid, but some of it goes into a non-exchangeable compartment, can no longer take part in fluid exchange, and if you want to maintain fluid, you have to give more fluid. This was later termed third space loss. It wasn't in this paper. And third space loss is very prominent, of course, in burns, and of course Parkland formula, same hospital, same people introduced that, still very active today, anaphylaxis and sepsis, of course. But they described it major surgery. And because it could amount to up to 15 mils per kilogram per hour, remember that figure, that's a litre plus an hour in the average patient, they propose even then to use a balanced salt solution such as lactated ringers or Hartmann's. And this paper has continued to influence intraoperative fluid management really for over 55 years. Interestingly, The study group consisted of only 13 patients, but it changed practice virtually overnight. People started pouring in fluids to patients. And the interesting thing was that when you got that fall in mean arterial pressure, it was presumed due to this third space loss if there was no other obvious cause. Of course there are other causes. We've mentioned venodilation, there may be cardiac depression with excessive anaesthesia, but they assumed this is probably due to third space loss, so excessive fluids were given. Only 6 years later, 1967, this statement was made in another paper. It's such a profound statement that it should really be printed out and put on the wall of every operating room around the world. In other words, what we should be doing is to maintain normal physiology and normal function with a normal blood volume, and importantly a normal functional body water and electrolytes. Now, as these authors said, this can never be achieved by inundation with fluids. Yes, you can maintain mean arterial pressure by pouring fluids in, but that would not keep physiology normal. It would be abnormal. Who were the authors of this paper? None other than Professor Moore, very famous surgeon in the United States, did a lot of work on shock, of course, and the author of that previous paper. They realized that people had gone too far, but it was too late. And in 2017, 50 years after this paper was published, patients are still receiving too much fluid and sodium with poor outcome. And I would guarantee that 95% to 99% of all operating rooms around the world, if they have a bag of fluid hanging there when you come in the morning, it will be a balanced salt solution, usually Hartmann's or lactated Ringer's, as a result of that original study. I'm saying it's still going on, and I'd just like to present data from a very good unit in York where they have a goal-directed strategy using fluids, but here in this study, David Yates, Simon Davis, Jonathan Wilson, were looking at the difference in fluid requirement using a colloid group, that's the HES group, hydroxyethyl start, versus a crystalloid group. I won't go in details, but I just want to look at the total fluid in the first 24 hours. In the colloid group you can see it was around about 2 litres of blinded fluid, and they still received Hartmann's, nearly 2,600. You can see the crystalloid group needed significantly more fluid, 3.2 litres, and they received again 2.5 to 3 litres, as it were, of Hartmann's solution. When we look at the total fluid these patients received, we can see in the first 24 hours had 4.5 litres and 600 millimoles of sodium, or 5.9 litres and 780 millimoles of sodium. Our daily fluid requirement is 2.5 litres. So in one group they had an excess of 2 litres, and in the second group an excess of 3.5 litres. Our daily requirement of sodium is 1 millimole per kilogram per day. In other words, the first group was getting an excess of 530 millimoles, and the crystalloid group was getting an excess of 700. That's 10 days extra sodium over and above that which was required. And you've got to have a jolly good reason, I think, to give that amount of sodium to somebody just because the patient's having major surgery. Because if you did that on the ward and the patient went into heart failure and died, you would be criminally responsible, and yet it's going on a daily basis. And this has led to many reviews, many editorials. This is one of the nicest ones by Gary Minter and Monty Mython. Number 1, third space loss does not occur during major surgery, full stop. And number 2, for heaven's sake, stop talking about Hartmann's or Ringer's lactate as a maintenance solution. It isn't. 1 litre contains 2 days worth of sodium. And in another newsletter published this time by Monty and Mike Grocott, Perioperative Fluid Management, Cheers to the Dream of Moderation, which was the title of that paper by Moore and Shires. So, should we be using liberal fluids to maintain mean arterial pressure, cardiac output, oxygen delivery? The answer to that is a resounding no. But we obviously still need to avoid hypotension, and we still need to maintain fluid to the patient. We need to avoid desiccation, as they said, drying out of the patient. So why not then accept the fact that we don't need to pour fluids into the patient and just try and maintain mean arterial pressure with the use of vasoactive agents? Well, this group in the United States published a paper in 2016. This is the American Society for Enhanced Recovery and the Perioperative Quality Initiative. It's a long document, it's a consensus statement, but in this document they made this statement about absolute hypovolemia. What they're saying basically is the observed changes in, for example, stroke volume variation after induction, fall in blood pressure, may not be due to hypovolemia, but may be due to vasodilation, in which case don't give fluids, give vasoconstrictors, and I'm emphasizing the word vasoconstrictors. So if we do that, if we follow their advice, do we still need to measure cardiac output? Can we just say, okay, let's just maintain the pressure? The answer to that is no, because this is a very reasonable, I think, result taken from a patient. Rather, maybe it's extreme. But here we're monitoring cardiac output, systemic vascular resistance, blood pressure, heart rate and stroke volume over a 10-hour procedure in a patient undergoing surgery in Japan using the LIDCO Rapid. This is the post hoc. This is the downloaded information after the operation. And at the same time, they're using their conventional flow monitor. And what we can see here is the starting cardiac output. This is pre-induction, around about 6 litres. And what we can see as soon as induction takes place, and for most of the operation, you can see that the cardiac output is down by about 70%. If we then look at stroke volume, we can see that that is the major reason why the cardiac output has dropped. So stroke volume is down, as is cardiac output. But if we're just basically concerned with maintaining mean arterial pressure, let's say around about 70 to 75, and we're interested in maintaining heart rate, in other words avoiding tachycardia, also an important thing, everything looks absolutely right. But you can see what's going on. The systemic vascular resistance has gone up dramatically with the vasoactive agents. So you can maintain heart rate and mean arterial pressure by giving vasoactive agents, but notice the effect on cardiac output and oxygen delivery, and we'll come back to that later. And interestingly enough, that increase in SVR may affect cerebral perfusion and oxygenation, as was shown in a study by Meng and Canison, which I'll also mention later. So we must be very careful when we're using vasoactive agents to first of all make sure our cardiac output is maintained, and secondly our tissue oxygenation is maintained. So we need a reliable flow monitor, and I think it's best certainly to start from pre-induction, try and maintain that value throughout the operation, and then try and keep it at that value till the patient's well enough to go back to the ward and the arterial line can come out, and so on. Now, in 2011, anaesthetists were encouraged, as I mentioned right at the beginning, by our National Institute for Health and Care Excellence to use an additional monitor, that's flow monitoring. And the initial advice came out on the CardioQ from Deltex, because Deltex asked NICE to examine some of the trials published with the CardioQ in the early 2000s, suggesting that outcome could be improved, and they recommended it. They said yes, it seems like a good monitor. Later their advice was extended to all flow monitors, irrespective of whether they've been validated to measure flow. Unlike Deltex, unlike LIDCO, many of these new monitors have not been properly validated to measure flow, so we must be very careful when we use them. The problem is, as soon as people started using flow monitors, there was this emphasis to try and maximize stroke volume by giving fluid up this so-called Frank-Starling curve until the last bolus of fluid did not produce any increase in stroke volume. Now, is this an appropriate strategy, and secondly, does it work? Well, I've just listed, I don't want you to read the details of this, but I've just listed some of the more recent studies on goal-directed fluid therapy, and I just want to emphasize here what's going on in terms of the patient population and in terms of the effect of that strategy on mortality. The POEMA study using the Nikon monitor, 50% 2 or less, look at the mortality 4.2 and 5.7%. This is usually 30 days. The optimized study, 60% ASA 2 or less overall, 5% and 6.5% mortality. This study by Gary Ackland, where they try to in post-operative period in the HDU restore oxygen delivery post-operatively to what it was pre-operatively, again 5% mortality. And then there are two studies on lower risk patients. Lay et al. Study I'll mention in a moment, and a study by Shalland et al. Using the Doppler, where the vast majority of patients were relatively fit, but still the mortality was around about 2%, and there was no difference in outcome between the intervention and the control group. I'll come back to this study later on, my own study, and Loredana will mention this study here amongst other studies. Now, I said I'd talk about this Lay study. This is a study on randomized control trial of stroke volume optimization during elective major abdominal surgery. It's a very well performed study using the LIDCO Rapid as their cardiac output monitor. Interestingly, all 220 patients underwent major abdominal surgery with an enhanced recovery protocol, ERAS, ERP, whatever you like to call it. All patients, interestingly, remember that figure of 15 mils per kilogram per hour from 1961? Well, they all received that, 13 mils per kilogram per hour, sodium-rich fluids, and the intervention group received an additional nearly a litre of colloid in the form of gelafusin. What about cardiac output? What about mean arterial pressure and oxygen delivery? Well, unlike the Doppler study, where the Doppler is put in after induction, and that's obviously a significant point, with the LIDCO they did have pre-induction values. Their pre-induction nominal oxygen delivery was amazingly 600 mils per minute per square metre, or roughly 1000 mils per minute in both groups of patients. Post-induction, you will now not be surprised to hear that both groups had a 30% fall in cardiac output over induction. So what happened after that? Was that pre-induction value restored? The answer was no. It remained at that 1/3 below, and indeed, funnily enough, in the control group, because they received less fluid, there was less hemodilution, and therefore their oxygen delivery was actually higher than the intervention group. So what was the result? Conclusion: algorithm-driven stroke volume optimization or maximization is of no benefit when superimposed on a liberal baseline fluid regimen in patients having elective major abdominal surgery. They did stratify them, interestingly, according to difference in fitness. My conclusion is that because you were only maintaining oxygen delivery at 2/3 of the starting value throughout the operation, you were getting build-up in oxygen debt in both groups, and it might have been better not to give so much fluid and just maintain venous tone rather than overloading the patient. So, in summary, can we say, why does flow monitoring as introduced not produce the expected benefits, especially reductions in mortality? Well, number one thing to say is that the enhanced recovery protocols introduced by Professor Kellett in Copenhagen, particularly used in Scandinavia, has improved outcome in the last 10 years. The latest randomized controlled trials using flow monitoring, where you've used this stroke volume maximization strategy, plus particularly with inotropes, has not reduced mortality and complications using that strategy. It's not physiological. And interestingly, we say third space loss does not occur during major surgery. Well, it is possible to damage the endothelial glycocalyx layer and actually precipitate third space loss in these patients. And that was well clarified by a paper from Daniel Chappell in Matthias Jakob's group, in this group in Munich, where they showed that excess fluid can damage the endothelial glycocalyx layer and therefore lead possibly to fluid loss. We know now from other trials using other dilution techniques that third space loss does not occur or is minimal during major surgery. But as you've seen, all reported trials except Optimize use their basic intervention was assuming that third space loss did occur. And the important point is, just because a patient is fluid responsive does not mean you need to be inundated with fluid and sodium. Patients will end up getting too much fluid and sodium, as we've seen. Inappropriate, maybe vasoactive compounds, which may lead to poor outcome. So just about a year ago, we actually had an editorial in an anaesthetic journal, Anaesthesia and Analgesia, a pro-con debate. So assuming you've got an enhanced recovery protocol going in your hospital for surgical patients, is goal-directed fluid therapy an essential element? Well, yes, it definitely is, according to Maxime Cannison and TJ Gann. But on the other end, on the other side of the ring, is Girish Joshi and Henrik Kellick saying, no, we don't believe that goal-directed fluid therapy is necessary if you're using enhanced recovery protocol. In other words, you can throw away your vascular monitors. We just need to give minimal amounts of fluid, and that's the end of it. So conclusion then on current practice might read not as much benefit, no effect on mortality when you're using enhanced recovery, and indeed a recent meta-analysis by Katie Rolland and Dilip Lobo from Nottingham in the UK suggested that goal-directed fluid therapy may not be of benefit to all elective patients undergoing major abdominal surgery, particularly those managed in the enhanced recovery setting. So where do we go from here? Do we just say, let's forget about flow monitoring, let's forget about all this monitoring, just we've got enhanced recovery protocol? Can we do better? Because we've seen in some of those enhanced recovery protocol studies, we're still getting 2 to 4 to 5% mortality. So there are two fundamental concepts which I think are essential to the rational hemodynamic management. Number one was venodilation, which I've already mentioned, and the second one, possibly as or even more important, factors which determine cardiac output. Venodilation, well, I don't want to say any more about that, to say that Chris Wolfe and I wrote a review of this subject in the International Journal of Surgery, and it's freely available to download if you want to read it, and it just covers what I've mentioned: venodilation, effect on preload, preemptive use of venoconstrictors to minimize fluid requirement, making the point about third space loss, making the point about the endothelial glycocalyx layer. But most importantly, I think, venodilation is a key component of anaesthesia which mimics the signs of hypovolemia. So you think the patient's hypovolemia, but in fact it's venodilation. So the implications for inappropriate hemodynamic management are considerable. So go back to this statement on the perioperative quality initiative. Remember, I showed this earlier, vasodilation and vasoconstrictors. In my humble opinion, it should read, for vasodilation, read venodilation, and for vasoconstrictors, it should read venoconstrictors. And then we'll get it about right. What about factors which determine cardiac output? Well, going back to the 50s, Guyton made the statement that the need of the body for oxygen is a real regulator of cardiac output. What does that mean in practice? Well, again, Chris Wolfe wrote this paper in 2007. I doubt if anybody in this room has read it. Cardiac output is determined by the metabolic needs of the tissues. That's what basically Guyton was saying, not the other way round. In other words, tissues generally regulate their own flow according to the metabolic demands. Summation of tissue flows will determine venous return, obviously stroke volume and cardiac output. But of course in anaesthesia, venous tone determines how much venous return actually gets back as preload, and we've seen that it's decreased by anaesthesia. So the venous blood may be returning, but it's not getting back to the heart. Okay, so the heart though is playing a permissive role. It doesn't regulate its own output. It responds to that venous return from the tissue. So that's what we should be maintaining, the venous return, not the other way around of pushing the heart by exogenous fluids to push blood back through the circulation. So that's not the right strategy. What we need to do is maintain venous return and pre-induction cardiac output in the elective high-risk patient. So the important point is, can improvements in intraoperative monitoring make a difference to this high morbidity and mortality? Well, about 8 years ago we sent this paper on, which was published in early 2010. Although there is now evidence to suggest that the use of individual new monitors can influence outcome, it will only be their combination that will radically improve the perioperative management and outcome of high-risk surgical patients. In 2011, John Louis Vincent gathered together a group of senior anaesthetists and intensivists to do an update on hemodynamic monitoring as a consensus. This was now published 6 years ago, and they made some very, very important points. No hemodynamic monitoring technique can improve outcome by itself. Correct. If the data are implied incorrectly, the result in management may actually not only not improve the patient outcome, may be deleterious. For example, the strategy of stroke volume maximization. Different monitoring techniques can sometimes be used to complement each other. For example, multimodal monitoring, I'd agree with that. Very important, they say, for heaven's sake, get away from this figure of 2.5 litres per square metre cardiac index or oxygen delivery of 600 mils and try and apply it to every patient from a 25-year-old to an 85-year-old. It is not. We're not all subject to the same controls. There are no optimal hemodynamic values. Correct. Variables should be combined and integrated. Well, we agree with that. And real-time information trends, changes from, for example, pre-induction are very useful. We don't necessarily have to have absolute values. So this, putting all this together, led to the development of this strategy, which we're using basically of intraoperative management of the high-risk elective elderly surgical patients, avoiding the build-up of oxygen debt. As we'll see in a moment, to avoid the build-up of oxygen debt, we need to be able to maintain pre-induction mean arterial pressure, cardiac output and oxygen delivery in our patients. And that requires us to use not only a reliable monitor from pre-induction, like LIDCO, but also keep an eye on hemoglobin and saturation, as we'll see. To be able to maintain this pre-induction, we need to have an adequate depth of anaesthesia. We can't have the patient too light or too deep. We need to use a monitor to do that. This is a common one. There are lots of other ones. For example, the one from Massimo, SEDline 03. We can also put a BIS monitor into LIDCO to have it on the same screen, as we'll see later. If we are doing a good job, we should be able to maintain cerebral and tissue oxygenation, and we can see that and assess that using a cerebral tissue oximeter. Put all that together allows us to individualize hemodynamic management in our patients, which is what we're trying to do. But I want to say a little bit about oxygen delivery. Just this is obviously just a review, a reminder of physiology, which I'm sure you are very aware of, which is the oxygen delivery equation. And basically it's of course a combination of hemoglobin, cardiac output and arterial saturation multiplied by Huffner's constant 1.34. The normal figures for hemoglobin in a normal patient would be 145 grams per litre, cardiac output 5 litres at rest, saturation 97%. Multiply all those together, you get 1000 mils a minute, or if you want it in square metres, 600 mils per minute per square metre. Fairly straightforward. What about oxygen consumed? Well, we don't consume all that oxygen, of course. We have quite a lot of oxygen returning to the heart. In fact, as we can see, it's about 75% of saturation, which of course allows us to do resuscitation using expired air. If it was zero, it wouldn't be very effective. That amounts to 750 mils per minute, so our oxygen consumption is therefore 1000 minus 750 is 250 mils per minute. And if you maintain that consumption in a normal person, how would you build up an oxygen debt if that's all you need? Shoemaker looked at oxygen debt very closely, and he said that the oxygen debt build-up during surgery was related to the difference between what the oxygen consumption was pre-operatively and what it was intraoperatively, and take one from the other and you could see how you build up oxygen debt. He obviously used in those days, 1992, pulmonary artery catheter and flow monitoring, but what he found, I think most interestingly, is in those patients, and there weren't that many, where oxygen delivery was maintained throughout surgery without a dip, as we've seen, oxygen debt did not build up. Of course, oxygen delivery can be reduced during surgery. We can get high-risk surgery with blood loss and hemodilution, and we can get figures not unreasonable, like hemoglobin of 100. This is 2 or 3 hours into a procedure. We've got cardiac outputs dropped to 3.5, saturations 90%. These are not unusual figures, but if you now multiply them all together, you don't have 1000. You've got 340 mils per minute. In other words, there's a 60% reduction in oxygen delivery. By what might be seen relatively minor changes in those three parameters. But you've got to remember the multiplier effect. A 20% reduction in three parameters such as hemoglobin, cardiac output and saturation will lead overall to a 50% reduction in oxygen delivery. So none of these values can be treated lightly. So we're getting oxygen debt build-up as a result. What are the consequences of a 60% fall in oxygen delivery? Well, we said oxygen delivery has fallen to 340 mils per minute. The oxygen available now is not all of that 340. Maximum extraction, the heart can extract a bit more as we know, but it's roughly, let's say 150 mils are now available. That's what the tissues are taking up. Debt build-up then is 250 minus 150. This is in simple terms. We're building up oxygen debt at 100 mils per minute. So during surgery, that's in the region of 6 litres an hour, or 3.5 litres per hour per square metre, or in 3 hours that would equate to roughly 10 litres of oxygen debt at the end of a 3-hour procedure in these circumstances. So, what's the evidence that this is causing us any problems? Well, we again go back to the Shoemaker study. The first statement he made was, in red, is patients experience shock during high-risk surgery. In other words, they're building up oxygen debt. And perioperative oxygen debt of 10 litres per square metre is tolerated, can usually be repaid post-operatively, just like if you run for the bus. You build up an oxygen debt and then you repay it. It's not going to kill you doing that, but clearly as that debt builds up, particularly in an elderly high-risk patient, when it accumulates to 30 litres per square metre, you will almost inevitably in his series go on to die. Now let's look at that figure more closely. This is the intraoperative period. What we're talking about basically here is that build-up. Now we're 24 to 36 hours post-op. The oxygen debt has continued to increase post-operatively, and at this point patients do not bounce back. These patients do, but they get complications. These patients survive without complications or organ failure. So let's look at that in more detail. Here we've got the end of the operation. And lo and behold, look what we've done. We've got about 10 litres per square metre of oxygen debt at the end of 3 hours. The problem with that is we don't know what's going to happen to this patient. Are they going to bounce back? If they're young and fit, they almost certainly will. Or will they do that? Or will they continue to build up more debt and therefore eventually die, as we said, the non-survivors in this group here? Emphasis has been on repayment of oxygen debt often in the HDU ICU. Prevention of oxygen debt in the OR, I think, is a much better strategy. The question, of course, then is it inevitable? And I think using multimodal monitoring, we can not only make it not happen, but we can restrict it to maybe 4 or 5 litres perhaps, to where the patient can easily repay that debt post-operatively. So what do we need then? We've mentioned already the flow monitoring. I'm not going to say any more about that. The second monitor is a monitor which really closes the loop and sees whether our practice is working or not, from pre-induction using some type of tissue oximeter right through to PACU. This is the INVOS system. It's a 4-channel near-infrared system. My own experience goes back now 16 years to 2001. I accumulated nearly 1,000 cases, again highlighting the fact they're the elderly, they're the long duration and high risk patients. But since INVOS came, the first clinically available one, we've had other ones from Casmed, Foresight, we've had non-in SenSmart, and we've now got a combined cerebral oximeter and a depth of anaesthesia monitor, the SedLine 03 from Massimo, which is now being used quite a lot now in Croatia. In my own practice, I would tend to use the cerebral oximeter on the right hand side and the BIS on the left, and on this particular patient I'm comparing BIS with the NeuroWave, which is another EEG based monitor. But the point being, of course, is it's very difficult to get bilateral if the electrodes are too big. It's usually one side or the other. How does it work? Well, basically you saw those pads. Well, a light emitting diode, 2 or more frequencies, pushes photons through the skin, subcutaneous tissue, bone into the brain, okay, and Many of those photons are basically just mopped up by the brain, as it were, but some of them take this banana-shaped arc back to the surface. The actual amount of tissue they're coming back from is only about the size of a thimble. We'll come back to that, about 1.5 cubic centimeters. The proximal arc detector picks up the ones that come from the surface, which of course have got nothing to do with cerebral oxygenation, and the distal one contains both, basically, both the distal ones from the brain and also the superficial. So basically a subtraction algorithm is used to determine cerebral versus superficial oxygenation, and that's been the basis of this INVOS oximeter and all subsequent oximeters that have been used. So what does it measure then? Well, it's not looking at the arteries or the veins, it's using mixed tissue oxygen saturation in a small sampling volume. This is called RSO2 or SCO2, and because the blood is mainly in the venous compartment in the brain, it's venous weighted, and so gives you a figure roughly of between 50 to 75% in a normal patient. Notice the range, same as if you use a mixed venous or sample from the internal jugular. There is a bandwidth of normal values in patients. So it's a capillary level measurement of primary venous blood, and it's an early indicator of changes in the adequacy of perfusion in the tissue under the sensor. So here we have the RSO2 and then the venue, and of course when you eventually get back to the heart, you're picking up venous blood from all over the place. Here we're just looking at a very small portion of the anterior cortex. So it reflects the oxygen supply demand of this small area. But it's an important area because right up here you've got the confluence of the anterior middle cerebral arteries, the so-called watershed region, and it's a region that's most likely to show some degree of reduction in oxygenation before often other regions do if overall oxygen delivery drops in relation to demand. And interestingly enough, the frontal lobe is the major area associated with executive function and cognition. So ability to carry out tasks, be able to map a journey from the middle of Zagreb down to Šibenik, for example, requires executive function, and that's one that may be affected by hypoxia in the anterior cerebral area. Now I mentioned that in healthy volunteers, although the average may be 70%, there is quite a bandwidth of values. But what we can also say in cardiac surgical patients, sicker patients, the average value is lower and the spread is much greater. And as Professor Matthias Herringlacher showed a few years ago, lower values in older cardiac surgical patients may be associated with poor outcome. My own series, which I'll mention at the end, showed a mean RS to 54, which is considerably lower, with some patients actually having values below 45 or 50. What numbers are important? Well, clearly, as you've seen, if you're using it in an elective patient, you must get a baseline value, because if you don't know the underlying value is only 45 or 6, you can't manage the patient. Just like you can't manage blood pressure too well, you need to get a starting value before you go on. If you then get a relative decline of 20% from baseline, it is significant in predicting out complications, because it probably is beginning to show that you're getting the maximum extraction. You may get deterioration in neuronal function, but that may lead to deterioration in neuronal integrity. So when the flow is restored, you may have some underlying neuronal damage, and that may lead to POCD, post-operative cognitive decline. An absolute decline below 50% may also be significant, but I'm not so certain about that. Okay, we want to avoid dropping the saturation. Well, what can we do about it? I've added a few things here. I want to emphasize 3 of them though. One is avoid low carbon dioxide in elderly patients. Don't overventilate. If anything, underventilate them. Keep the arterial CO2 up. Very important to increase mean arterial pressure and increase cardiac output at the same time, as I mentioned. It's easy, as we've seen, to increase mean arterial pressure, but it may result in a reduction in cardiac output, and this is important, as I mentioned earlier, about the effect on cerebral oxygenation. But always in the elderly, consider increasing arterial oxygen content. We've seen the effect of the lower oxygen content. If the hemoglobin drops on oxygen delivery, you have got, if that is reflected in a low cerebral oxygenation, increase the hemoglobin from say 80 grams to 100 grams, and that will often correct the problem. So why then is it important? Well, I think John Merkin in London, Ontario put forward the concept which is correct of the brain as the index organ. Now I've added there, especially in elderly patients. What did he mean by that? Well, as we've seen, if oxygen delivery is insufficient, tissues and organs become hypoxic. Okay, they're not getting enough oxygen. They're building up oxygen debt, and if that can't be repaid quickly, it may lead to organ dysfunction and complications, and then mortality. But that may not occur immediately. It may be many days. The sequence of organ failure may go over several days with a deficiency in oxygen delivery. The question is, how do we detect during surgery that tissues are becoming hypoxic? Well, the concept of the brain as the index organ suggests that signs of hypoxemia will begin to be shown in falls in RSO2 prior to serious hypoxemia elsewhere. Merkin suggests that the brain will be the best monitor. I think it is a very good monitor, but especially in elderly. I think younger patients can maintain cerebral oxygenation. We don't have a lot of evidence about this for much longer than the elderly patient. In fact, if we could monitor the gut more easily, it would probably be an even better monitor. But the important point, I think, is maintaining cerebral and tissue oxygenation from pre-induction should ensure that we're getting adequate overall tissue oxygenation and we are minimizing the build-up of oxygen debt. This just gives you a clinical example. This is a chap undergoing nephrectomy. This is his systolic pressure. This is oxygen saturation, around about 100. Everything looks fine. We're also maintaining flow, in this case with esophageal Doppler. This chap underwent a period of 1.5 litres of blood loss, and that blood loss was actually given fluid in place of that for a while, and then blood itself. But if we look at the cerebral oxygenation, we can see during that period of blood loss there was a 25% drop in cerebral oxygenation. While we kept the pressure up by giving fluids, replacing it with fluids, and then we started giving blood, and we see the cerebral oxygenation coming back up. So the RSO2 recovers following blood transfusion, and just maintaining hemodynamics can lead to a significant fall in cerebral oxygenation. But is that significant? You might say, well, sorry, so what? Well, we've done a lot of work on cerebral oxygenation during awake carotid surgery, and in this particular example we see that when the clamp went on there was a 27% drop in RSO2 on the side that we were operating on. This drop led to the patient becoming unconscious immediately, and we put a shunt in, and as soon as the saturation came back the patient woke up. I think that's pretty good evidence. I would not want, for example, that to continue, because if it's only for surgeons really quick, over 10 to 15 minutes, it may not lead to any long-term harm, but I would rather avoid a 25-30 minute period of hypoxemia. I'd like to know what's going on in this patient. And of course other people say, well, okay, I maybe accept, but does it happen very often? Do you get desaturation very often during major surgery? And in a paper I wrote in 2007, 10 years ago now, 30% of elderly patients may well desaturate, mainly due to blood loss. So it is a common problem. So what about the role in improving outcome? And I'm only going to mention non-cardiac surgery, and one has to accept there's very little evidence basically out there, unfortunately. Very few trials have been performed. The only one I think of significance is this one by the late Andrew Casati, 120 patients randomized to maintaining cerebral oxygenation versus not, where it's being monitored. And really one of the results of this trial, I haven't got time to go into details, showed that those patients who desaturated, and not all of them did, in those who did, then the more they desaturated, the more complications they got, and the greater the length of stay. And as Thomas Sheeran said, professor in Groningen, Measuring and obtaining adequate tissue oxygenation may prevent post-operative complications and may thus be cost effective, and I think it provides evidence that we're doing the right strategy in our individual patient to try and maintain a delivery of oxygen. This review by Annelies Merman and Stefan de Hert, Stefan is well known to attend meetings here in Croatia, basically made the point that cerebral oximetry could be the standard monitor of the future, but making a very important point that it will only improve outcome if it's used with part of a comprehensive monitoring strategy. We wrote a review earlier in this year, myself and Gudrun Kunz from King's, on cerebral oximetry and its role in adult cardiac, non-cardiac surgery and resuscitation from cardiac arrest, and made the point that despite the attraction, I mean, it seems that everybody would be clamoring, I want to measure cerebral oxygenation in my patients, for heaven's sake. Good grief, it's a part of the brain. But some of the reasons why this hasn't taken off, one of course of which is cost, but that's another matter. So in conclusion, I think it's a great monitor. I think correction of desaturation seems to reduce complications, and the important point is, even if you use conventional monitoring, you still need, with flow and depth of anaesthesia, you still need cerebral oximetry, and I think Loredana will show some examples of that. The third monitor in this strategy is one I think we're much more used to using, and so I'm not going to say very much about it, is a depth of anaesthesia monitor, not too deep and not too light. And what do these monitors actually measure? Well, it's not only anaesthesia. They can be affected by temperature, natural sleep, ischemia, neurological disease, etc. But generally speaking, this work done by Malk Al-Kiri showed that BIS index is a measure of cortical suppression. So as you get cortical suppression, and this is uptake, a functional MRI study, as you get uptake of glucose diminishes with increasing anaesthesia with isoflurane or propofol, there is a relationship with the number of BIS and the degree of cortical suppression as measured by uptake of glucose. Now, of course, every patient is afraid that they might be awake during surgery, so there are some recommendations saying you could keep the patient relatively deep. We'll avoid it. Well, of course, but hang on a minute. Is it also bad to have excessive cortical suppression? And this was recognised again by our National Institute for Health and Care Excellence, where they suggested that patients who are at higher risk of excessively deep levels of anaesthesia would include older patients and indeed patients with poor cardiovascular function. That was based on the evidence available in 2012. And why you have to start saying, well, why might this be the case? Why is it elderly? Well, as you increase anaesthetic concentration along the x-axis, you're going to get cardiovascular depression and possibly neuronal toxicity, although people, of course, argue about that. No question, if the patient's too light, you may get explicit recall, accidental awareness under GA, or indeed, if you believe that these anaesthetics give you some protection, you lose some of your neuronal protection. But if you take your average fit and healthy patient, then the low risk patient has got a very big target to hit with your anaesthetic. It's difficult. If you get it, even if you do get it wrong, the chances of major problems at either end are not really very great. This is not true of your elderly or high risk patient, where conventional wisdom says they don't need much anaesthetic, and there's a narrower bandwidth between having the patient too deep and too light. But of course, a lot of elderly patients may need more anaesthetic than we imagine. It's very difficult to say where the elderly patient lies along the x-axis. Very difficult. But all of them do have this close, narrow bandwidth, in my opinion. But there is more evidence now that excessive cortical suppression is bad for high-risk patients, and this is the CODA trial. Nearly 1,000 patients randomized to BIS, target 40 to 60 versus normal care, BIS recorded but not visible, major non-cardiac surgery, and they were able to discriminate between BIS group and the BIS group which was monitored but not available. So there was a distinction. The BIS group 53, the BIS but not available 36. What was the result? Well, for every 1,000 elderly patients you would reduce delirium, very important, predictor of poor outcome, by 83 cases and 23 cases of post-operative cognitive decline. Now, BIS is important not only in terms of preventing too low a figure, but also looking at its relationship with hypotension and also the requirement for anaesthesia, this so-called triple low, where your mean arterial pressure is low, your BIS is low, and you are not requiring to give the patient much anaesthetic. There have been many studies which have gone basically in opposite directions. It's not very clear, but this latest one in 2015 by Willingham and Mike Avidan's group got together a large amount of information from their 3 trials on awareness. That's the Be Unaware, the Bag Recall and the Mitchin Awareness study, and overall they were able to find 13,200 cases, and what they found was a clear relationship. The longer you had this triple low, the greater the mortality, both at 30 days and 90 days. And if you look at 90-day survival, Kaplan-Meier, these are the patients who didn't have triple low or less than 15 minutes. The patient had triple low greater than 15 minutes. They found basically that the likelihood of 30 and 90-day mortality increased approximately 10% for every 15 cumulative minutes of triple low states after controlling for known confounders. So it wasn't just that these patients were ill, it was these values. So low BIS is not an epiphenomenon. It's not inevitable in an elderly patient, and we've shown similar studies, similar results. This is the average BIS in our very high risk vascular surgical patients, and you can see the average BIS is 45, but you do need to make a lot of effort to control the amount of anaesthetic you're giving, and Loredana will show you an example of that. I think there was a 5-fold variation, so from anything from 1.8 milligrams per kilogram per hour up to 9 milligrams per kilogram per hour to keep the BIS in this normal range. So that was 4.5 was the average, but you can see the spread of requirements for propofol. So if you're not prepared to alter your propofol or your anaesthetic, or you don't believe, it's not going to produce any benefit from depth of anaesthesia monitoring. Now we actually combined both these in a trial, depth of anaesthesia and cerebral oxygenation, and had a rapid and a massive reduction in cognitive decline in this study published in 2012. Why is it important? Well, I've mentioned most of it, but those who are interested in reading this, an open access journal, really this made the case, this study, for depth of anaesthesia and cerebral oximetry alongside flow monitoring as a strategy for reducing oxygen debt. Now, as a result of some of these studies, we have now recommendations from the American Geriatric Society to use process EEG monitors to reduce delirium during general anaesthesia and in older patients even for sedation. We do also, interestingly, have recommendations for using multimodal monitoring, and this is the association from the UK published 5 years ago, nearly 6 years ago. Management of proximal femoral fractures, we'll hear about that later. They suggested that we should consider using cardiac output, depth of anaesthesia and cerebral oxygenation, but I suggest in the United Kingdom there is virtually nobody who's using that combination, but it is suggested as a strategy. And of course when you start doing that, you then have to think to yourself, how do we integrate multimodal monitoring into our daily anaesthesia practice? Because we're adding to conventional monitoring depth of anaesthesia, cerebral oximetry, well, we can combine those two now, and we need to have flow monitoring, but as we've seen, we need to have flow monitoring and pressure monitoring going on continuously, not only with an arterial line but possibly with a finger cuff in these high risk patients. And this was what we started to do in 2009. It was the first ever case where the CNAP waveform was used and analysed by LIDCO PulseCo algorithm. This was the first case where it was used, and subsequently it was integrated into the BIS monitor, into the LIDCO monitor CNAP device, and subsequently BIS was also attached via USB. So not only do we get continuous blood pressure, but we also get continuous BIS non-invasively. Does this strategy work? Well, we looked at basically 120 consecutive very high risk vascular surgical patients. All of them were ASA 3, some ASA 4. I think there might have been one ASA 2 patients. They were about to undergo femdistal bypass, the vast majority, very high risk procedure, long duration, great potential for oxygen debt obviously. Their mean nominal cardiac output and cerebral oxygenation we were able to maintain at 87% or above pre-induction value, so we did a pretty good job of maintaining oxygen delivery in these patients. BIS was kept around about 44, as you've seen. Very low fluid requirement, only 5 mL per kilogram per hour. Amputation rate at 1 year, only 2%. Only 8% needed HDU or ICU. Most went back to the ward from the post-anaesthesia care unit within a few hours. 80% required HDU in the optimised trial. No inotropes were used apart from phenylephrine ephedrine, and our 30-day mortality was 0.8%. One patient died within 30 days, and the predicted was 5 to 10% using VPOSSUM scoring. So I think multimodal monitoring minimises fluid and sodium input, will reduce use of inotropes, still maintains oxygen delivery, reduces the need for HDU, and has potential, I think, to improve outcome, reduce mortality in a large group of patients. So when we look at these figures I showed you, then just putting this into perspective, just 1% of patients were ASA2 or less in our group, and the mortality was 0.8 versus predicted of 9. Now, of course, this was not a randomized trial. It's a very complex intervention strategy, but it does at least show there is a potential for getting better results. And this trial at the bottom, Loredana will present some of the data. So very briefly, in the last few minutes, how do we do it? Loredana will give you some information of how it's done in practice. When you're used to it, you can probably ignore what I'm going to say now, some of it anyway, but I think when you're starting, you say to, well, yeah, okay, I'm sold on this. How do we do it? Well, basically, you attach the LIDCO rapid monitor with a CNAP or intraarterial blood pressure, and of course LIDCO can use either, and you get your baseline for mean arterial pressure, obviously, but cardiac output, oxygen delivery, BIS, and ideally cerebral oximetry. You then begin your low-dose veno-constricting phenylephrine or noradrenaline infusion, where you put 5 to 10 mL per hour of 10 milligrams or 1 milligram noradrenaline 50 mL, and then you induce and maintain anesthesia with a BIS of 40 to 55. Ideally, you want to see the patient in what we call the normal box, where the mean arterial pressure is plus or minus maybe 10% of target, and the cardiac output is plus or minus 10% of target. And in that case, if everything's at target, do nothing. Just give a tiny amount of fluid, keep your fingers crossed that it maintains that way, just observe for changes. Here we've got the situation where the normal cardiac output is okay, but the mean arterial pressure is a bit low, and what we need to do is we accept we need to raise the pressure a little bit, and we can do that giving perhaps phenylephrine or noradrenaline to get that back up again. No problem really. In this group, basically, we need to restore normal cardiac output. Mean arterial pressure is in the normal range, but normal cardiac output is low. And here we would give look at stroke volume variation, which may be high, and if it's high, then we would give fluids plus or minus phenylephrine or noradrenaline. If it's low, we would give ephedrine or an inotrope. In this group, both mean arterial pressure and normal cardiac output are below the normal range, and here we need to restore mean arterial pressure and normal cardiac output. And here we again would look at the stroke volume variation. If it's high, then we would start off first priority, get the blood pressure up with phenylephrine or adrenaline, and then add fluids. And here, if it's low, we would use ephedrine or another inotrope to get it back to normal. So the advantage, I think, of multimodal monitoring for the high-risk patients, it provides greater insight into intraoperative physiological changes in conventional monitoring. It allows for individualized management centered on minimizing bill of oxygen debt, and I think should improve outcome. And the important point is this burgeoning of high-risk patients, I think, mandates a new perioperative anesthetic management strategy alongside enhanced recovery to reduce the requirement for expensive HDU and ICU, to decrease hospital length of stay, to reduce the cost of perioperative care, and to reduce patient morbidity and mortality. So in the future, I think it should become routine to use this strategy, and it is achievable now using non-invasive and minimum invasive flow monitors alongside depth of anesthesia and cerebral oxygenation. So thank you for listening.